GRACE, the global resource for advancing cancer education, is proud to offer this presentation by Dr. Heather Wakelee, medical oncologist at the Stanford Cancer Center of Stanford University, on current questions in clinical trials in post-operative, also known as adjuvant therapy, for resected non-small cell lung cancer. This program is made possible through an educational grant from GlaxoSmithKline. A transcript as well as a PDF file with copies of figures associated with this program are available at www.cancergrace.org/GRACEcasts.
Hi, I'm Heather Wakelee. I'm a medical oncologist at Stanford University, and I'm going to be talking about adjuvant therapy for non-small cell lung cancer, really focusing though on the current questions and ongoing clinical trials. So in this first slide, I'm reviewing the LACE meta-analysis, which looked at 5 of the largest recent adjuvant trials that use cisplatin-based chemotherapy. And this included 5 trials, over 4,500 patients who were followed for approximately 5 years. The overall survival hazard ratio in combining these trials was 0.89, statistically significant, translating into approximately a 5% overall survival benefit at 5 years. However, there was a lot of variability by stage. So patients with stage 1A, and there weren't very many of them, but for those that were included in those 5 trials, the hazard ratio was actually 1.40, indicating potential harm in these patients with small stage 1 tumors. In the stage 1B patients, hazard ratio 0.93, not reaching statistically significant, but hinting at benefit in that group. And in the stage 2 and 3 patients, hazard ratio of 0.83, robustly statistically significant, indicating definite benefit in this group with adjuvant cisplatin-based chemotherapy. So that's where we're starting. We're going to be focusing on the new questions, ongoing trials, really looking at predictors of benefit, as well as some of the newer targeted agents that are being developed. So focusing now on the prognostic and predictive factors, which is this next slide, the prognostic markers are those that indicate a survival benefit or detriment, regardless of therapy. These include things like stage, tumor size, sex of the patient, and from a molecular standpoint, ERCC1, MSH2, and P53 are some of the markers that we can look at that indicate a survival benefit regardless of treatment. The predictive markers are those that predict for a differential benefit from a particular therapy, and those include ERCC1, RRM1, thymidylate synthase, EGFR mutations, and we'll talk more about those. I'm going to focus on some of the other predictive markers in non-small cell lung cancer. There are several that have emerged that are more of genomic signatures, in particular a 15-gene signature that was examined in the JBR10 study. That was one of the adjuvant cisplatin-based studies looking at cisplatin vinorelbine as adjuvant treatment versus observation. And there was a 15-gene signature that emerged as being predictive for patients who would benefit more from treatment. I wanted to highlight that all of the prognostic and predictive factors that have been looked at so far have all come out of retrospective analyses in early-stage lung cancer. Some of the other predictive markers that we know about come from advanced stage non-small cell lung cancer. In general, low levels of these indicate sensitivity to treatment. So low levels of ERCC1 indicate sensitivity to platinum, low levels of thymidylate synthase, sensitivity to pemetrexed, low levels of RRM1, gemcitabine sensitivity, and low levels of BRCA1 platinum sensitivity, but high levels actually indicate sensitivity to taxanes. And then with EGFR mutations, that's indicative of sensitivity to EGFR tyrosine kinase inhibitors. In this next slide, I show the results from the YALT trial, which was again one of the large adjuvant studies, looking at ERCC1. Now, ERCC1 is a DNA repair enzyme, and patients with low levels would be predicted to have additional benefit from chemotherapy. And you see on the left, the survival curve for patients who had low ERCC1 or ERCC1 negative tumors did have a substantial benefit from chemotherapy compared to the control arm with a hazard ratio of 0.65. However, in patients who had ERCC1 high or positive tumors, it was predicted that they would not have benefit from chemotherapy. And you can see here that was the case with the control arm up above the chemotherapy arm, showing that chemotherapy was potentially harmful in that group. In this next slide, I show 5 ongoing trials that are prospectively designed studies of these biomarkers in adjuvant treatment of non-small cell lung cancer, where in all of these studies, patients after complete resection have their tumors analyzed for various markers, which can predict for sensitivity to various treatments. And as an example, in the SWOG 0720 study, patients with stage 1 tumor resected are randomized to either get cisplatin and gemcitabine chemotherapy or not. And it's really not a randomization, but they are selected for whether or not to receive that chemotherapy based on levels of ERCC1 and RRM1, which again, with low levels predicting benefit from those drugs. This is a small study. It's really a pilot to see if it's feasible to do this. There are larger trials ongoing in Europe in which patients do undergo a randomization, and they either get randomized to a standard arm where all patients get the chemotherapy. In the case of the ITICA trial, they all get cisplatin pemetrexed. However, for those on the experimental arm, they are assigned various treatments based on their ERCC1 level and TS levels. And the same for these other European trials. The control arm gets standard treatment, and the experimental arm is treated based on their levels of these proteins. In this next slide, I talk about the phase 3 targeted therapy adjuvant trials. I'm highlighting 3 large phase 3 trials. The RADIANT trial is looking at Erlotinib, the MAGRIT trial looking at a MAGE A3 vaccine, and the ECOG 1505, which looks at adjuvant Bevacizumab, and I'll go into more details on these. So this was the JBR21 study looking at Erlotinib given as second or third line treatment for advanced stage non-small cell lung cancer. This was the study that got the drug approved in North America, and highlighting here the response rate of approximately 9% in an unselected patient population, progression-free survival benefit, and about a 2-month overall survival benefit. Again, showing the activity of this drug in an unselected patient population for advanced stage disease. So this then led to the RADIANT trial highlighted on this next slide, looking at adjuvant non-small cell lung cancer plus or minus Erlotinib. This is a study of nearly 1,000 patients, all with resected stage 1 to 3A non-small cell lung cancer, who have at least had a lobectomy, and they are required to have evidence of EGFR expression either by immunohistochemistry or by FISH. Chemotherapy can be given, but it's not required. Patients are stratified by histology, sex, age, their EGFR status, as well as their smoking status, and whether or not they've received the adjuvant chemotherapy. They're then randomized in a 2-to-1 fashion to either get 2 years of Erlotinib at the standard 150 milligrams orally daily versus a placebo arm. And disease-free survival is the primary endpoint. The next study I want to highlight is the adjuvant vaccine trial with MAGE A3, and this is in the next slide. The MAGE A3 is a cancer-specific tumor antigen which is found in up to 50% of lung cancers. It's really not found in normal tissue. That's why it's a very good cancer-specific target. And basically what's given is a purified recombinant protein along with an immunological adjuvant, and that's a GSK compound. There was a phase 2 trial done which showed very minimal toxicity, consisting almost primarily of local reactions. And the randomized phase 2 results were very encouraging, which led to this slide, which I have highlighted next, the MAGRIT adjuvant non-small cell lung cancer trial. And in this study, over 2,000 patients need to be screened, and that again has to do with the fact that the MAGE A3 expression is in less than half of patients. Again, this is for stage 1B to 3 patients who have at least had a lobectomy. Those who do express the MAGE A3 protein after receiving adjuvant chemotherapy or not, and that's the choice of the investigator, are then randomized to either get the vaccine, which is given as a subcutaneous injection, 13 injections over a 27-month period, or they are randomized to receive placebo injections. Disease-free survival, again, is the primary endpoint, and this trial is ongoing. The third pathway I wanted to emphasize that's involved in an adjuvant trial is with Bevacizumab. I've outlined in this next slide the data from advanced stage disease. This is 2 studies, the ECOG 4599, which was in nearly 900 patients, carboplatin paclitaxel plus or minus Bevacizumab, which showed a 2-month survival benefit in advanced stage disease. This was the first drug which was shown to provide a survival benefit when added to first-line chemotherapy. The AVAIL trial done with cisplatin and gemcitabine did not show that same survival benefit, but again showed a strong response and progression-free survival benefit. So that's the data from advanced stage disease. The rationale, again, for doing this trial is on the next slide, showing, again, there was this benefit of adjuvant chemotherapy for resected non-small cell lung cancer, which has been clearly established. The benefit of VEGF inhibition, I just showed in the last slide. So the next logical step was to bring anti-angiogenesis treatment with bevacizumab into the adjuvant setting. We are allowing for 4 different chemotherapy choices since there really hasn't been an establishment of the optimal chemotherapy for adjuvant treatment. And there's a lot of controversy over treatment of stage 1B, so we limit it to patients with larger tumors, at least 4 centimeters in size. On the next slide, I show the schema for ECOG 1505. The goal is to enroll 1,500 patients with resected stage 1B to 3A non-small cell lung cancer. Again, for the 1B patients, they have to be at least 4 centimeters in size. And again, required for a lobectomy, no prior chemotherapy, no planned radiation. Patients are stratified by stage, histology, sex, as well as the chemotherapy regimen that they're given. And there are 4 chemotherapy options: cisplatin vinorelbine, cisplatin docetaxel, cisplatin gemcitabine, or cisplatin pemetrexed. The cisplatin pemetrexed is restricted just to those with non-squamous histology. Patients are randomized and either receive 4 cycles of adjuvant cisplatin-based chemotherapy or the same chemotherapy with the addition of bevacizumab. The bevacizumab is then continued for a full year every 3 weeks, and overall survival is the primary endpoint. Conclusions: adjuvant cisplatin chemotherapy is the standard of care for patients with resected stage 2 to 3A non-small cell lung cancer. Long-term follow-up is really important in all of these trials. The most critical issues that remain are better patient selection, and I believe that's going to come through looking at ERCC1, RRM1, thymidylate synthase, and other markers of chemotherapy sensitivity. We also need to be developing better drugs, and I've highlighted 3 of those in the ongoing randomized phase 3 trials, looking at EGFR inhibition in the RADIANT trial, looking at vaccines in the MAGRIT trial, and looking at VEGF inhibition in the ECOG 1505 trial with bevacizumab.